So minimally invasive transforaminal lumbar interbody fusion is a procedure where the offending facet joint at the level of the pathology is removed. That allows access to the spinal canal, allows space to access the disc without having to retract on the nerve significantly. We then remove the cartilage from the disc, place a spacer that recreates the normal height and shape of the disc, put in bone graft. We typically use something called bone morphogenic protein, which does an excellent job of getting the bone to heal. And then screws are placed into the spine called pedicle screws that secure the spine in place until the bone heals. People typically ask about the screw placement in a lumbar fusion, and there are only three things that can happen when you place screws in the lumbar spine. One, the desired outcome, which is the bone heals. Two, the screw gets loose or the screw breaks. So if the bone doesn't heal, the screws will either get loose or break. That's a sign that there's something going wrong with the surgery. But in over 90% of the cases, the bone heals just fine, and the screws no longer carry any load once the bone heals, and they just sit there. About 10% of the time, we'll remove the screws after a year. That's typically in patients that do a lot of bending, lifting, and twisting. Since our screws are placed percutaneously and we have normal muscle covering the screws, they can sometimes poke a little bit when people bend, lift, and twist. But most patients that don't have bending, lifting, twisting jobs have no problem tolerating the screws. The indications for surgery include instability, degenerative disc disease, and post-laminectomy syndrome. Those are the primary reasons why we do minimally invasive approaches for adult degenerative disease in the lumbar spine. So risk for a minimally invasive transforaminal lumbar interbody fusion is similar to the risks for any spine fusion procedure. They include things like death, paralysis, infection, bleeding, pain, need for future surgery, risks of anesthesia, risks of spinal fluid leak. The advantage of doing it minimally invasively is these risks are minimized because there's less collateral damage to the tissues, there's less risk for infection, there's faster recovery, there's less blood loss, and there's some growing evidence that adjacent segment degeneration is minimized in minimally invasive surgeries because the dynamic stabilizers of the paraspinous muscles of the back are intact and functional. If you look at the data from the Spine Patient Outcomes Research Trial, or SPORT study, a multi-center national trial looking at degenerative spondylolisthesis and lumbar fusions, the average hospital stay in the United States for a one-level lumbar fusion is approximately 4.5 days. The average operative blood loss is about 360 cc's. Approximately 1/3 of patients require a blood transfusion. Average operative time is approximately 240 minutes. So when we compare that data to our minimally invasive transforaminal lumbar interbody fusion data, we find that average stay in the outpatient center is about 4.5 hours. Average blood loss is approximately 100 cc's. Average operative time is approximately 100 minutes. So the advantages in terms of morbidity, blood loss, time of surgery, time of recovery, and risk for infection is incredibly lower with minimally invasive transforaminal lumbar interbody fusion compared to open lumbar procedures. The benefits of minimally invasive transforaminal lumbar interbody fusion are that you can decompress the spinal canal posteriorly, you can stabilize the spine, and you can do it through a very, very small incision. Retractors that we typically use for a minimally invasive TLIF are 18 millimeters in diameter. To put that into perspective, a dime is 18.5 millimeters in diameter and doesn't actually fit down the retractor. So it's a lot like building a ship in a bottle. So the limitations after a minimally invasive transforaminal lumbar interbody fusion are no bending, lifting, or twisting for 3 months. Since it takes that long for the bone to heal, any bending, lifting, or twisting directly loads the graft placed in the disc space and the pedicle screws. So there are limitations to how strong the screws are and how well they can be fixed into bone. and we don't want to find those limitations. If you fracture your tibia and you ask it to heal back to itself, it takes an average of 16 weeks. So asking 12 weeks for two different bones to grow together and be one solid piece of bone is pretty reasonable. Typically, patients who are sedentary or have desk work can return to work 2 weeks after surgery. That's typically when people start to drive. If you do any heavy bending, lifting, or twisting, we need to wait to 3 months, because once again, if you start too soon, you're simply testing how strong those screws and the implants are. Oftentimes, we'll start patients on a physical therapy program at the 3-month mark once we're assured that the bone is healed by x-ray. For the results to be long-term, durable, and good, the bone has to heal. So we go through great lengths to ensure that we get bony healing. We encourage patients to start on calcium and vitamin D, both preoperatively and for 3 months postoperatively. It's one of the reasons why we use the pedicle screws to hold the spine stable while the bone grows together. And that's also why we use bone morphogenic protein for bone graft to encourage the bone to heal. Because if the bone doesn't heal, it is a problem and can require further surgery.